Hi, good afternoon, everyone. Thanks a lot for joining the webinar today. So the topic for our discussion today is on personalized medicines for cancer care, for the better treatment outcome and management of unwanted side effects for breast cancer and lung cancer. This event is co-organized by Mount Alvernia Hospital and Icon Cancer Center with the support from Modifiable. And today we are very happy to have two of our expert panelists who are Dr. Lee Guek and also Dr. Shang Yeap, who are joining us. And both of them actually are the experts in their respective field in breast cancer and lung cancer. And definitely we will hear a lot of sharing from them today. So before we start the discussion, I would like to just do a very quick introductions for both our panelists for today. So Dr. Lee Guek, Dr. Lee is a senior consultant and medical oncologist with Icon Cancer Center, Singapore. Prior to joining Icon, she was trained at the Dana-Farber Cancer Institute and also practiced at the National Cancer Center of Singapore. Her subspecialty interests are in breast cancer, especially those young women with breast cancer and those with pregnancy-associated breast cancer. So for the first section, Dr. Lee will actually share more of her experience on managing the breast cancer and what are the key things to look out for. Then for our second section for today, Dr. Shang Yeap, Dr. Yeap, who is a senior consultant and medical oncologist with Icon Cancer Center of Singapore. He's completed his specialist training at Crown Princess Mary Cancer Center in Sydney and later practiced at Johns Hopkins, Singapore, and he's still having a session with Tan Tock Seng Hospital currently. His subspecialty interests are in lung cancer, urogenital, gastrointestinal cancers, and also melanoma. Okay, so just for your information, for this Facebook Live event, in case you have any question, you can actually put it under the Facebook Live chat functions, and then I will actually raise it to both of the panelists today. So you can actually have this interaction with both the panels, and then you can have some of your questions in your mind answered as well. Okay. So for the first section, we'll actually welcome Dr. Lee. Okay, and for the first section with Dr. Lee, our discussion will focus more on the breast cancer because definitely Dr. Lee is one of the key experts in managing breast cancer patients. So I think while we are waiting for some questions to come in, I think we can keep the discussion rolling. So perhaps I think for Dr. Lee, we know that breast cancer is one of the most common, it's not one of the most, but in fact it's the most common cancer in females. So perhaps you can tell us how is the incidence changes in the past decades for breast cancer. We heard a lot of people say the cancer patient actually getting younger. So is it true for breast cancer as well?
Okay, so I think it's a good start to talk about the incidence rate. If we compare in the 70s to maybe in 2015, because the most updated figures are, we're still waiting for it. So we do see a tripling in the incidence rate over the years. So we are really talking about maybe 20 over per 100,000 in the 70s. And I think the latest figure that we could get hold of in 2015, this figure actually rose to about 60 plus per 100,000. So that is really a tripling. I think the good news I think we can focus on is that even despite the increase in incidence rate, we do see that the mortality rate is not increasing as dramatically. So the mortality rate is still more or less stable. And we like to attribute that also because in part to screening, which really helps to pick up breast cancer in the early stage, which are then very treatable. I think the next question also asks about young women with breast cancer. And I have to admit that, I do see quite a lot of young women in my practice. Is it more common now? I think statistics-wise, we are not really seeing much higher statistics. But the issue is that, which is also a good thing, is that more and more women, they are, I think, getting more aware of the possibility that cancer not only happens in older older patients, and they are more likely to do self-breast examination and go for screening and highlight any changes to their doctors. So we are seeing what we seem to be seeing, that there's an increase in the young women with breast cancer as well.
Yeah, but when we talk about increase in incidence, is there any clear reasons of why? Is it because increased screening, or is it because of environmental reasons? What is the reason we are seeing incidence?
So we see more and more early stage cancer, and that is probably due to screening. But the exact reason why there are more cancers is really nobody has the answer. But of course we can link that to certain risk factors, risk factors associated with cancer. For risk factors, we usually like to dichotomize it into modifiable risk factors or non-modifiable risk factors. The reason we do this is so that we can act on the modifiable risk factors and encourage people to do something about it. So for the modifiable risk factors, we are really talking about obesity, unhealthy lifestyle, and even drinking, smoking, or the use of hormone replacement therapy when women undergo menopause. The non-modifiable risk factor, unfortunately, we can't do anything about, and they really include factors such as aging and being women. That is unfortunately two main risk factors that we can't do anything about. And things like, early start of menstruation, late stopping of menopause, because these two factors actually prolong the time that, the female body is exposed to female hormones. And also, of course, like certain race are also predisposed to cancer.
Okay, so what are the common symptoms related with the breast cancer that is actually a red alert that you might actually need to go to see a doctor?
So I think it's important to look out for some fairly obvious changes. The most obvious one, of course, is a breast lump. And to discover that, we really encourage women to do self-breast examination regularly, like once a month, so that you understand and you're aware of your own body, so that if there are any changes, you can know. Other changes will include asymmetry. If you notice a new onset asymmetry, or skin changes like persistent changes in the skin, or even like bloody discharge, or even nipple discharge, things like that. Those will be red flags. Having said that, I don't want to alarm a lot of people, because even if you have all these changes, it may or may not be cancer. But I would like to encourage women to be aware, so that if there are any changes, just flag it out to your doctor. Go and see a doctor, so that more detailed examination can be carried out.
Yeah, but when you talk about the self-examinations or the cancer screening, when should a woman actually start all this self-examination or screening per se? Is a risk the same across the young women, or at a certain cutoff you should start to be more worried about all this examination?
So I think maybe it's good to know about what our national screening program does. So in Singapore, we have national screening programs, and when we talk about breast cancer screening, we really encourage women like 50 years and above to go for mammography. It's readily available. You need to do it when you're 50 years and above. You need to do it maybe once every 2 years. For women who are 40 to 49, they can actually discuss with their doctors with regards to whether they should do it and how frequently they should do it. Between this age group, usually we recommend yearly. And if you're even younger, but if you have a strong family history, or you have a strong personal history, then it's advisable for you to really talk to your doctor to discuss, breast screening at earlier age.
Okay, so beside the self-screening and also the self-examination, how is breast cancer really diagnosed in the clinical setting? Let's say a patient come into our clinics, how do you confirm that it is instead of breast cancer?
Okay, so we do a few things. First of all, of course, we do a clinical examination. We examine the patient to take note of the shape, the of course, on whether there is a lump, how big is the lump. And then this will be followed by imaging investigations such as mammography. So we do a mammogram to ascertain whether there is indeed a mass or suspicion. Then followed by this, if there is really a mass both on clinical examination or mammogram, then we will proceed with a biopsy, which really means that we take out a sample of the tissue to look at it and to see whether it's cancerous. So all this investigation together will help us to arrive at the diagnosis.
Okay, I see. Yeah. So when we talk about breast cancer also, I believe there's a lot of time genetic counseling might be necessary. So is it applicable for all the patients, or who in what kind of patient will need to go through a genetic counseling?
So we don't do genetic testing for all patients. There are limited resources, and also they may not all patients will benefit from it. So we select patients, especially if they are young, like more than 40 years old, but this age cutoff is different in different countries. And if there are multiple like cancer in the same individual, young onset or strong family history, or unusual cancer like a male breast cancer in the family. So all this will prompt us to discuss genetic counseling as well as testing.
Okay, I see. So so after you confirm that patient actually have the breast cancer, what is the treatments like? What is a typical treatment option available for the patient and the treatment flow?
So the treatment plan for each individual is really different. We individualize it. The reason being, we look at the tumor characteristic. It's important to understand first the stage of the cancer, the biology of the cancer, whether it's aggressive or not aggressive. If it belongs to the more aggressive subtype, we may even consider giving chemotherapy first before further treatment. And I mean, the normal treatment usually will encompasses, multidisciplinary approach for early stage cancer. Usually the patient will require removal of the primary tumor, which is the breast cancer. And then depending on the risk of the patient, then we will recommend either, chemotherapy, hormonal treatment, radiotherapy, or a combination of all this. Of course, I mean, in the case of diagnosis of stage 4 cancer, then we will proceed usually with systemic treatment in the form of chemotherapy, targeted therapy, or hormone therapy first.
Okay. And also a lot of time, I think we heard about the hormonal treatments in breast cancer. So is it something common or applicable for all the patients, or is only for a subset of patients? How you know actually that patient is suitable for hormonal treatment?
So we look at the profile of the cancer. So for breast cancer, we really subtype it. And how do we subtype it? We actually look at the presence or absence of hormone receptors or a particular receptor called HER2. So when we talk about hormone receptor, we are talking about estrogen receptor, progesterone receptor, and then we look at the HER2 receptor. So based on these three subtyping, we can get like hormone receptor positive or HER2 negative, or hormone receptor negative, HER2 negative, a different combination. So really the hormone treatment is really effective for patients with hormone receptor positive breast cancer.
Okay, so I think from your sharing, we know there's quite a number of different treatment options, chemo to surgery to hormonal treatments. Does all these treatments affect fertility of the patients? Because I think this will be a concern of a lot of young women who got a cancer and they are still want to have a baby. So does all this treatment actually affect the fertility for them?
I think this is a very important question because, in modern era, women are postponing childbirth and even starting a family. So sometimes, when women are diagnosed with cancer, especially young women, they may not even have completed their family. I do have patients who come to me, with just gotten married with a new breast cancer diagnosis. So I think it's very important, and I will discuss with them, about their family planning, whether they have completed their family, and what is their desire for children. So different individuals will have different plans. for the future. But for women who really desire childbirth after a breast cancer diagnosis and before treatment, I will really encourage them to go and see a gynecologist for fertility preservation. So in Singapore, or in elsewhere in the world, the gold standard for fertility preservation is really embryo cryopreservation. In the past, women may have the misconception that you have no time to do fertility preservation before starting systemic treatment like chemotherapy. But now we do have workflows in place. We can even achieve embryo cryopreservation in a short span of 2 to 3 weeks and start chemotherapy immediately after. So in ICON, we really recognize that this is a very important journey for the patients. And we have a young women cancer program where we help the patients to tackle issues like fertility, like genetic hereditary disease, and bring them through, from their diagnosis, and also provide support for all these multiple issues that young women may face.
Yeah, I believe this is something very important because sometimes we heard about certain story. I'm not sure it's true. It's like sometimes from the dramas or some of the documentary, we can see a lot of women actually sacrifice or delay their own treatment because of the babies or fertility issue. So I believe this, with all this program in hand, definitely it will help the women to actually to fight the cancer while actually achieving their lifetime goal at the same time. Yeah. So thanks a lot, Dr. Lee, for giving a quick overview of cancer, breast cancer management. So we have some questions coming in from the Facebook live chat. So I will read it out for Dr. Lee to address it. So the first question, I believe, is I'm not sure it's a myth or if there's any proof on it, because this is something I've been wondering for myself for some time, and a lot of people have been talking about it, is whether lumps, perhaps the benign lumps, will be possible to become cancerous.
So it really depends on, what exactly is a lump. Breast lump can be anything. It can be fibroadenoma, it can be cyst. So we really need to characterize, even benign lump, we need to characterize it. Some of the benign lumps may be associated with an increased risk of cancer later on. So I think for any women, if they discover a lump, I think it's important to get the lumps worked out. And then we need to really characterize the lump to give you, a prognosis of what will happen later on.
Okay, so the advice is, let's say you discover any lumps, you have to see a doctor consultations. But it's actually for let's say it's a benign lump, is it any treatment that is needed, or is again it's case by case basis? So let's say it's a benign lump. So what is the most usual treatments available, or what's the next step?
So to ascertain that it is really benign, we look at the imaging. The radiologist will look at the imaging. There will be some, factors that are associated with a higher degree of suspicion for it being cancerous. So we look at the imaging. If we need to confirm it, then we do a biopsy. But if it's benign, usually, if it's confirmed and it is proven to be benign, what happens is that we usually follow up. Because you have lump, and especially if it's a new onset, we tend to want to follow up, maybe a repeat in either ultrasound or mammogram. It can be anywhere from 3 months to 6 months, depending on how suspicious looking the lump is. So for women with a new lump, the advice is to get it, evaluated to see whether it's indeed benign. If it's benign, then your doctor will make the appropriate recommendation depending on the imaging result as well as the biopsy result to see how frequent you need to be follow up.
Okay, so we have a next question, which is on the survival rate. So the question is, what is the survival rates for young cancer patients? Do they have a better chance to recover over than the older patients?
So when we talk about survival rates, it really depends on the stage of diagnosis and the biology of the tumor. So we know that, stage 1, 2, 3, and 4, they have different survival rate. So we don't really differentiate young versus old for early stage cancer. It really then boils down to the stage and the biology. So we know that, stage 1 cancer, they have a survival rate, 5-year survival rate of more than 90%. And then stage 2, probably 80, and then this number will decrease with higher stage, obviously. Yeah.
Okay. And the next question is closely related with the previous one. So, what's the survival rate for patients with recurrence?
Yeah. So then it depends, on the site of recurrence. So for recurrence, we usually dichotomize it into local regional recurrence, which is still highly treatable, versus a systemic recurrence. When we talk about systemic recurrence, we are talking about the cancer, when it comes back, it goes to other organs. So it can go to, lymph node, bones, lung, liver, even brain. So unfortunately, if the cancer recur in a systemic fashion, then it is a stage 4 disease. While we are not able to completely cure the patient, it is still highly treatable, and we still have a lot of medicine for this patient.
Okay, actually, I think it's rather interesting to talk about the survival rate. So we also know that actually breast cancer, there's different subtypes. So is the survival rate different from one cancer subtype to another?
So we know, for subtypes, we actually separate it into hormone receptor positive and HER2 positive and triple negative. We know that the hormone receptor positive tumors, they tend to be a bit more indolent. They grow more slowly. When we compare this to HER2 positive and triple negative, this too belongs to the more aggressive breast cancer subtype. So in the past, actually HER2 positive disease, they were deemed to be of a poorer prognosis because they are quite aggressive. But, in recent years, with, more and more newer HER2 targeted therapy, actually we see that these patients are, living better and longer. For triple negative breast cancer, it is indeed a more aggressive breast cancer subtype. If we talk about stage 4 setting, the low survival will likely be a triple negative breast cancer.
Okay, I see. So the next question is also about recurrence, and the patients and the audience would like to know in the DCIS cancer, what is the risk like for recurrence?
So DCIS is really in situ stage 0 cancer. So, if we want to be very technical and very strict with, terming it, then we wouldn't term it as, cancer, because when we talk about like breast cancer, it is really stage 1 to stage 3, where it's associated with, a number for recurrence. But when we talk about DCIS, it is treatable because we can then remove it. And if the patient undergoes, the appropriate treatment, like either a removal or, plus minus hormone therapy or even radiation therapy, usually the likelihood of recurrence is very low.
Okay. So the next question is, I believe Dr. Lee already addressed it earlier. I will just read it out. The question actually reads, if someone recovers from breast cancer, what is the likelihood of recurrence? I believe this is something we already addressed earlier. So we'll move on to the next questions. So the next question is, how likely is recurrent in the stage 3 HER2 Yeap positive breast cancer, which have spread to a lymph node without hormonal treatments? Yeah, so what's the likelihood for recurrence in the stage 3 cancers?
So the recurrence rate for stage 3 cancer is definitely higher than stage 1 and stage 2. So, baseline breast cancer because it's cancer, so we are talking about, there is already a recurrence risk. The higher stage you go, the higher the likelihood of recurrence, especially when it's hormone receptor positive. Then the use of hormone treatment actually reduce the recurrent risk relatively by, we're talking about 30-40% relative reduction of breast cancer risk. So I would really urge the patient or this individual to really talk to your doctor to initiate the appropriate treatment for the disease stated.
Okay, so the next question is very closely related. So in case a patients have a recurrence, can they actually or cannot they go through the same treatments during the recurrence, or usually you will advise them to switch to the other treatments when recurrence?
So when there is a breast cancer recurrence, the first step is actually to do a repeat biopsy to determine the biology of the breast cancer, because your first cancer could be hormone receptor positive or could even be HER2 positive. But when the cancer comes back, it can have changes to all these receptor status, and it may then warrant a different method of treatment. So first of all, when there's a recurrence, we always rebiopsy. We will characterize the cancer that we are treating, and then we decide on what is the most appropriate treatment targeting the biology.
Okay. So is it true that during the recurrence, on what degree we will actually see the recurrence as a new cancer altogether, or that there will be still some associated with the previous one?
Generally, when the cancer recurs, there's a high chance that it retains the same profile. But for different subtype, the variation is different. There is actually a 10 to 30% chance that there will be a difference in the receptor status.
So the next questions, I think the topic changed a little bit. So we are actually it's also along that line on recurrence. So, so the audience actually say, in case a patient recover from a breast cancer, what are the risks of her to getting other type of cancer? Are the family also at risk?
So, I mean, usually, when we talk about like a person having cancer, does it increase the other risk? It will only increase the other risk of getting cancer, provided the patient potentially have a hereditary condition that predispose them, or a type of mutation that predispose them to getting multiple cancer. So then it boils down to, at what age that individual has developed the first cancer. If the patient developed the cancer at an early stage, like very young onset, then we would potentially advise the patient to get genetic counseling and testing. So if there is a hereditary cancer gene, then there is a possibility that it's a syndrome that the patient may get multiple cancer and the family members may be at risk. But if we talk about a lady who only gotten the first diagnosis at maybe 60 years of age, the likelihood of it being hereditary cancer, I mean, it's never zero, but it's less likely.
And also, I think when we talk about hereditary cancers or genetic related cancer, for breast cancer, I think one of the key things people always heard about is BRCA genes. So what is BRCA genes? And I think one of the questions for myself is also, does BRCA genes also affect men? Because we know a lot of time we talk about BRCA genes is a breast cancer or even like ovarian cancer. But let's say a man have a BRCA genes mutation, does it affect men as well?
So BRCA gene is really a breast cancer associated gene. I think, not sure if all of you are familiar with the Angelina Jolie effect. So basically, she was diagnosed with BRCA1, right?
Yeah.
So
I actually, a lot of people heard BRCA genes is because of Angelina Jolie, because I think he's one of the most high-profile celebrity with these mutations. Yeah.
Exactly. So when we talk about BRCA, we talk about BRCA1 and BRCA2. So what exactly are BRCA genes? They basically, they're basically BRCA1, BRCA2 genes, and they produces, proteins that helps to repair the genetic material of our body. So, when our cells will die and they need to constantly, renew itself. So when this happens, we need the genetic material to be passed on accurately. So when there is a damage in this gene, it actually affects the repair process, and the genetic material can then be altered during, renewal, and this will leads to, cancer formation. So basically, this is what the BRCA gene is about. It affects actually women and male, as in it can be passed down to both females and males. So it not only predisposes to breast cancer and ovarian cancer, but these two are the most common ones. Other cancers associated with BRCA1 genes include like pancreatic cancer, even prostate cancer in men. So for high-risk family history, young onset cancer, and multiple cancer, or even, like male breast cancer in the family, then we will advise them to get the genetic testing.
Okay. So I think we will move the discussions towards more on from the treatments and recurrent more toward the side effects, because this is one of the key area of discussion as well. So when we talk about the side effect related with the breast cancer treatments, we know there are so many different types of treatments, but what are some of the key common side effects you will actually see when it's come to managing the cancer patients?
So I think one thing is important to note is that actually different people will respond very differently to chemotherapy. So some people, they may breeze through treatment. For some, they may get the side effects, worse than others. So, usually what I tell my patient is that you may hear horror story, but, it may or may not happen to you. You just have to try it to see, how your body takes the treatment. So the most common side effects will include, nausea, vomiting, hair loss, maybe lower immunity, and also like organ damage could potentially happen, but it's not common. So these are some of the more common side effects.
Okay, I see. We have questions coming in from the live chat, and this about the side effects of hormonal treatments. Yeah. So, and also he have questions on whether that even if we have injections for the bone loss, I believe it's for the prevention of the bone loss for such treatments, how much can it actually mitigate the bone loss during hormonal treatment?
So when we talk about hormone treatment, we are talking about like premenopausal hormone treatment or postmenopausal hormone treatment. One of the side effects for postmenopausal women that we are treating with aromatase inhibitor will include, bone loss and osteoporosis. So this is one of the known side effects. Of course, if a patient is diagnosed at a later stage in life where they are older, already, they may already have some degree of bone loss. So we need to usually ascertain a baseline to see how, good or how bad their bone density is. And then when we recommend the treatment, we will follow up with, either yearly or 2-yearly bone mineral density tests. If there is a need, then we will supplement with injection, like what this person mentioned. The injection actually is a treatment for osteoporosis. Usually we see quite a good result from all this treatment, but a lot will still depend on the patient. We always encourage patients to continue with a healthy lifestyle, even exercising, walking, weight-bearing exercise. All this can help in addition to the injection to help to mitigate bone loss as well.
Okay, thanks Dr. Lee for answering that questions. So just now, I believe you mentioned some of the common side effects includes nausea and vomiting. And I believe it's quite interesting because I read in some of the articles, in fact, nausea and vomiting is one of the most concerned side effects for most of the patients, not only breast cancer patients, but for most patients receiving chemotherapy. And also we believe that in a lot of drama or movie when the patient's receiving chemo, usually the first reaction we saw is they actually have this very bad nausea and vomiting. So is it true in real life? And if let's say that happened, what kind of treatment options are available for them?
So of course, it's not as dramatic. Usually, usually the patients wouldn't suffer such a bad episode of nausea and vomiting. The reason being, we always pre-medicate the patients. So when they are going to go for chemotherapy, usually before the chemotherapy starts, we will give injections for anti-nausea, anti-vomiting medicine, and even once they finish their chemotherapy, when they go home, we give them a pack of medicine to bring home to target all this nausea and vomiting. It's important to recognize that in modern era there are actually a lot of medications for there are antiemetics to treat nausea and vomiting. So I think from last time to now, I think things have changed a lot. There's a lot of improvement. In fact, most of the patients I'm treating, they do not have significant, nausea, vomiting. That's usually one of the least side effects that they are getting.
Okay, I believe there's a sort of like a myth-buster, especially with the improvement in terms of the preemptive treatments or antiemetics, which is available for the patients. So I believe that the other key concern for women, especially in breast cancer, when they are receiving a treatment, is the hair loss, especially for young women. So what is your advice on this area? And is this hair loss permanent? Or they will actually get better after they stop the treatment?
So it's definitely not permanent. So, the hair loss is due to the chemotherapy side effects. So once we stop the chemotherapy, once they complete their treatment, the hair will slowly grow back. And even during the chemotherapy, if they really feel very self-conscious, you can always get a wig, you can wear a cap, you can still look fashionable with scarves. So these are not permanent side effects from the chemotherapy. And usually once the chemotherapy is done, the patient, the immunity and all that will come back slowly. The patient will feel okay after that.
Mm-hmm. And if I'm not wrong, actually, not all the chemotherapy is associated with hair loss, right? Is it
generally right? Yeah, that's correct. So there are non-hair losing regimen, but for breast cancer and early stage breast cancer, all the regimens include hair loss regimens. However, for other drugs that we use in the metastatic stage 4 setting, some of these drugs will not cause hair loss.
Okay, thanks a lot, Dr. Lee. So I think before we end this section and move on to Dr. Yeap, I think I will just ask one of the last questions. I believe it's actually applicable also. It's actually about the preemptive mastectomy. So especially for those already discovered with BRCA mutations, do you think, what's your thoughts on that? Is a preemptive mastectomy necessary?
So this is a highly personal question for the patient, because some patients will be able to accept it, but some will not be. Preemptive prophylactic mastectomy, as what we say, it helps to prevent breast cancer recurrence or breast cancer development in BRCA 1 and 2 patients. The efficacy is as high as 95 to 99%. However, it's not 100% because despite the surgery, there will inevitably be some tissue left behind. But it does, reduce dramatically the percentage of getting breast cancer development.
So I believe the best option is still, let's say you have any of this concern, to consult with the expert like Dr. Lee, so that we can actually come up with a more personalized decisions for your treatments. Okay, so thanks, Dr. Lee, for sharing your opinions during these sections. In case the audience, if you have any further question, you can still write it down under the live chat options. We will actually get Dr. Lee back again after Dr. Yeap's sections. So in case there's any other further question, we could try to address it by then as well. So thanks, Dr. Lee.
Thank you.
Yeah, so now we will welcome Dr. Yeap for the next section. Hi, Dr. Yeap.
Hi.
Okay, so as I mentioned earlier, Dr. Yeap is one of the key experts on the lung cancer management. So now we have to switch our channel a little bit from the breast cancer into a lung cancer. So same things, in case you have any questions, I think today is a very good chance for you to get your answer from this expert. Yeah. So while we are waiting for some of the questions to coming in, I think same thing, we would like to actually, perhaps Dr. Yeap could give us a quick overview in terms of the lung cancer management. So we know that breast cancer is the most common cancer in women. Well, on the other hand, lung cancer, we know that last time for males, colorectal cancer is the most common, but now lung already become the most common cancer among males. And we know that the incidence in female also is increasing. So perhaps you can tell us more about the trend of the diagnosis for lung cancer and why you think we actually see all these kind of changes in incidence.
Okay, good. Yeah, so lung cancer, right, actually is the most common cause of cancer deaths. So that's why it's an important cancer. You know, in terms of cancer incidence, is one of the highest. It's the highest among men in the world. In Singapore, for men, colorectal cancer is actually still the highest cancer for men. And then in Singapore, and lung cancer is number 2. But in terms of deaths from cancer, lung cancer is the number 1 cancer. So unfortunately, many people will know someone who has been affected by lung cancer before. Now, the treatment for lung cancer is obviously improving a lot. You know, so many years ago, people who get diagnosed with lung cancer often will not survive for very long, and really we're talking about a year was about the average. And these days, obviously, it's a lot better because really all the greatest advances in cancer treatment in the last few years have all been in the field of, a lot of it has mainly been in the field of lung cancer. So later on, we can address a lot of the treatments for lung cancer. Lung cancer incidence, obviously, is high, mainly because of smoking. You know, so smoking is still the main cause of lung cancer. Now, smoking, if you smoke, often you won't get lung cancer like, you know, a few weeks after you smoke, right? You're going to get it like many decades later. So people that we see getting lung cancer, people who were smoking maybe in the 70s or 80s before, really we started to see a decrease in the incidence of smoking. Thankfully, the message for smoking, you know, has gone through, and certainly we're seeing a lot less people smoking these days, and that's why the lung cancer death rates are also coming down.
Okay, I see. But we do understand that in the population there are a group of patients who are non-smoker or never smoker who also been diagnosed with lung cancer as well. So what is the incidence like, and is it getting more common?
Yeah, so I think that is the worrying factor, right? Because all along we've always been brought up, all of us, you know, in this society, to think that only smokers get lung cancer. And in fact, you know, if we had done a lung cancer talk like, you know, 15 years ago, 20 years ago, I can tell you hardly anybody would ever turn up, because often the people who got lung cancer or were interested in lung cancer were smokers, and a lot of smokers had less interest in finding out about their cancer. But that has all changed, because unfortunately what we're starting to see now is non-smokers getting lung cancer, and then suddenly that worries everybody, because to think that last time you think like only if I smoke then I'll get lung cancer, or if I'm exposed to secondary smoke then I'll get lung cancer. But now we're seeing people who have never smoked before and are getting lung cancer. Now, and worldwide, that makes up about 20% of all lung cancers. So that's quite a lot, you know. So out of every 5 patients that I may see with lung cancer, 1 of them will be someone who has never smoked before. Now in Singapore, it's even more concerning, because in Singapore, that number is a little bit higher. It's actually 30%. So out of 10 patients who I see with lung cancer, 3 of them would be people who have never smoked before. And often I'll be honest with you, just in the last 2 weeks, I had two such patients, two young female who were just going around, doing their normal work and all that, and they presented with cough. One of them with cough, one of them with no symptoms at all, and suddenly to be told that they had lung cancer, and they were really in shock, because they just never ever imagined why they would get lung cancer, when all along they think that only smokers get lung cancer.
Yeah.
So we are seeing we do see a lot of people in Singapore, non-smokers getting lung cancer. Now, don't ask me why, because we don't really know why. There's a lot of research right now as to why this is the case. Now, obviously, genetics it plays a big role in this. Why we're seeing a lot. Particularly, we know that worldwide, it's a lot of Asians who fall into this category of non-smokers. So unfortunately, in Singapore, that's most of us. Non-Asian, just being Asian alone, you're more likely to have a chance of getting lung cancer even you're a non-smoker. So genetics definitely plays a big role. The only theories we have is that for some reason, some people have some genetics that make them very sensitive to lung carcinogens. Lung carcinogens are just, maybe they may be more extra sensitive, even though they are non-smokers, they may be more sensitive to secondary smoke. And just having a little bit of exposure to secondary smoke may increase their risk of getting lung cancer. Likewise, with exposure to any other carcinogens that cause lung cancer, they are a lot more sensitive. So that's the only clue we have right now, but we still don't know what exactly are the genes that cause lung cancer. Unlike what you were talking about earlier about BRCA mutation in breast cancer, we don't have a similar LRCA or lung cancer kind of mutation, we don't know any particular genetic mutation that causes lung cancer.
But when you talk about smoker and non-smoker, when they get a lung cancer, is there any differences in terms of characteristic or the treatment outcome for them?
Yeah. So the kind of cancers that smokers get and the kind of cancers that non-smokers get, even though it's all considered lung cancer, they're actually quite different. Smokers in particularly have a high chance of getting this particular cancer called small cell lung cancer. And you almost never ever see a non-smoker get that kind of cancer, small cell lung cancer. Small cell lung cancer is usually one of the most aggressive type of cancers, very fast growing, spreads very fast and difficult to treat. Whereas the non-smokers tend to get a non-small cell lung cancer. And these kind of cancers tend to be a bit less aggressive and usually respond to certain treatments which smokers don't respond to. So I mean, if you want to go into detail, and the type of lung cancers that non-smokers get, the common type is what we call EGFR mutant lung cancers. Now, so I think today our topic is about personalized medicine, right? So the important thing to know is that in lung cancer, the most important thing we need to know about lung cancer is actually the type of lung cancer. There's many, many different types. So we can talk a bit about that. I know you can ask me other questions, but others I'll be talking too much.
No worry. I think all this is a good sharing. But I think the next questions to link the discussion is what is the red flag that you might be for individual to notice what are the common symptoms for lung cancer? So when do you might be suspecting yourself might be got a lung cancer and it's a time to see a doctor? Yeah.
Okay. Now we'll have to be honest here. The lung cancer is not like breast cancer. Breast cancer can be picked up early. Why? Because number one, we have a special screening program for breast cancer. So women above the age of 40 are encouraged to go for screening, and so you can pick up breast cancer in the very early stages. And of course, the benefit of picking up breast cancer early is that it's very much more curable. Lung cancer, on the other hand, there isn't really a great screening program for lung cancer. And so often, by the time patients have symptoms from lung cancer, it's often a later stage, and that's why patients don't do as well as compared to breast cancer patients. Now, so the symptoms that patients may have are often later stage symptoms. in the early stage, the important thing to know is that very few lung cancer patients have any symptoms at all. So you can imagine, like, our lungs are quite big, right? And if you have even just like a 2 cm or 3 cm lung cancer, you may not feel anything. You will have absolutely zero symptoms. By the time they have symptoms, they are often more advanced. Now, what are the common symptoms? The common symptoms are all related to do with your lungs. So you may have a cough, you may have cough and bleeding, you may have difficulty breathing, and you may have chest pain. So all these symptoms are commonly due to the actual lump in the lung. So your lump if it's a big mass in the lung, it can cause the cough. Often, if it's close to a blood vessel, or the tumor itself bleeds, then it causes bleeding or coughing out blood. And cough. I think the important thing to say is that if you only have a cough for like 1 or 2 weeks and it goes away, it's not going to be lung cancer. It's what we call a chronic cough. So you really shouldn't ignore a chronic cough. A chronic cough being something that lasts more than a month, you really should see a doctor to investigate that. Generally, any cough with any blood as well shouldn't be ignored, because that's often the first sign either of lung cancer or a bad lung infection. So either way, you shouldn't ignore it. And then difficulty breathing as well, and chest pain are the other common symptoms.
Okay. So in your clinics, let's say a patient's coming into clinics, how you do a confirmative diagnosis of lung cancer? Is this same like breast cancer? You will do all the workup plus confirmations?
Yeah. So for lung cancer, also we rely on scans, first of all. Now you might, when you first see a GP or you see the polyclinic, they might ask for a chest x-ray. The chest x-ray may or may not pick up the lung cancer, but if the lung cancer is quite big, then it will show up even on the chest x-ray. But the chest x-ray is usually not as accurate, so often by the time there's a suspicion of lung cancer, then you might need a CT scan or a CAT scan to look at the lung, and you get a more detailed look into the lung. Now, a scan alone can never confirm if a patient has lung cancer. The only way to confirm if a patient has lung cancer is to do a biopsy. Now, biopsy is just to put a needle into the lung and to get some tissue and to see whether there's any lung cancer cells in it. A biopsy can be done either through the skin by the radiologist, that means the people who do your scans. It's quite simple. They just give you a bit of local anesthetic and they put a needle into the lung and draw out some tissue. Usually, preferably, if it's possible, that's the way we do it, because it's quite fast and quite safe. But obviously, another fairly safe way to do it is actually to do a scope into the lung. So many people would have heard of, colonoscopies, where we do put a camera into the colon, but you can do the same with the lung as well. So you can do a bronchoscopy and have a look at the camera into the lung, and then you see the tumor, you try to get some tissue. So ideally, almost all patients will get a CT scan, and then they'll get a biopsy. Once the lung cancer is confirmed, then the next thing they'll need to know is how advanced the lung cancer is. So many patients will then go on to have a PET scan. PET scan is the most accurate scan for looking at whether the cancer cells have spread to other parts of the body. Okay.
So what are the common treatment options like for lung cancer? We noted that most lung cancer, when we discover or diagnose them, it's already at a later stage. So surgery is still one of the options for them?
Yep, that's right. So the treatment options for lung cancer is actually similar to breast cancer and many other cancers. The three main treatments that we always have for cancer are always surgery, radiation, chemotherapy, or chemotherapy, or rather you call it systemic treatment, because sometimes it's not chemotherapy, it's tablets, But usually these are the main three. And so it's the same for lung cancer. If lung cancer happens to be picked up very early, then often we'll send the patient for surgery. At the later stages, sometimes radiation together with chemotherapy may also work. And then in the advanced stages, what we call the stage 4 setting, where it becomes difficult or very difficult to cure the patient, then sometimes it's what we call chemotherapy or systemic treatment.
Okay. And I think this is applicable for all cancer types, but especially for lung cancer. In the past years, actually, we see the implication of precision medicine and molecular testing actually getting more and more importance. Perhaps you can tell us how this actually benefit the patients.
Yep. So that's where the biggest breakthrough has been for cancer. Is really a lot of it is in lung cancer. And why is because we now know a lot more about lung cancer than we did like 20 years ago. 20 years ago, you know, it was very sad. We only know whether a cancer is small cell lung cancer or non-small cell lung cancer. And you know, for many years, we had no breakthroughs, you know, for lung cancer. We just found that 2 chemotherapy drugs are better than 1 chemotherapy drug, which is very sad. After like 10 years, that's the only breakthrough we had. So now that's all changed in the last 15 years or so. How it's changed is that we've gone down to the molecular biology of lung cancer. We now know not just the type of lung cancer, like whether it's small cell, non-small cell. We also know a lot more about the mutation, so the genetics of the lung cancer. And that's why this term personalized medicine. Personalized medicine is especially applicable for lung cancer because almost it's impossible as lung cancer patients, or if you're a lung cancer support group, to compare notes. You can't compare the treatment that, as a lung cancer patient, you can't compare the treatment you're having compared to some other lung cancer patient. And the reason is because the genetics of each lung cancer are so different. So how we decide who gets what treatment really depends on the genetic profile of the lung cancer. So every single patient who gets diagnosed with lung cancer will have some sort of genetic test done. Now that genetic test is to look specifically at what mutations are in your lung cancer. What we're really looking for are these special mutations called driver mutations. Now, driver mutations are mutations that drive the lung cancer. And often in many lung cancers, you will find often you find at least one driver mutation. So one particular mutation that's really pushing this lung cancer along. Now, thankfully, we now have a lot of drugs to put a brake onto these driver mutations. So you know, often the most common one in Singapore is this particular mutation called the EGFR mutation. It's up to about 50-60% of lung cancer patients in Singapore will have this mutation. And we have a very effective treatment for it called, and these treatments are often tablets. So they're not chemotherapy, they're called targeted therapy. They're called targeted therapy because, you know, unlike chemotherapy, will affect other good cells. These targeted therapy really just target the mutants and target the cancer cells. So they're effective and we have a lot less compared to chemotherapy. So the thing about lung cancer is to find out whether there is any particular mutation. And once you find out the mutation, then you treat it with the appropriate targeted therapy.
Okay. So I think just in general, how many percentage of the patients will be eligible for this kind of targetable treatments? Just a ballpark figure. Is it
in
common
Singapore,
that you
know, it's quite so especially among the non-smokers, like I said, up to 60% of 60% of them will have these mutations. So the majority of all Singaporean patients with lung cancer will have a driver mutation that we will be able to target and treat.
Okay, I believe this is really a good news for most of the lung cancer patients with the advance in technology and also available of new treatments. We can actually see the improvement in treatment outcome for majority of them. Okay, so we got some questions coming in from live chat, so I think we could start to address it. Yeah, so I think the first question definitely is from a smoker. So he's asking whether is vaping as bad as smoking. So, you know, I don't do see
interesting question from Singapore because it's actually not allowed. Yeah. I mean, access to vaping in Singapore is limited, unlike places like Europe, you know, where it's actually quite common. Now, obviously, vaping being fairly new, we don't have a lot of information about it. Now, we do think, but there is some evidence that may not be as bad as usual tobacco smoke, but there's definitely some tobacco-based carcinogens in vaping as well. So certainly it is not safe, and at the moment, even though it's very new, probably not as bad as smoking, but also bad. So don't find illegal means to get it in Singapore. Yeah. You shouldn't be able to. If you can get it, don't.
Yeah, and I believe that, let's say this is a part of the concerns, then you should, I think as much as possible, you should stop both of them vaping and smoking. Yeah.
Yes.
Okay, so the second question is also more on smoking. So the question is actually whether is second-hand smoker at high risk of getting lung cancer?
Yeah. So that's a very relevant question, right? Because I think there are many people who don't smoke but know that they have exposure to secondhand smoke. Now, secondhand smoke, unfortunately, is a well-proven lung cancer risk factor as well. So we do know now that secondhand smoking, will increase your risk of getting lung cancer. Now, of course, it is not as high as the patient who smokes. But at the same time, secondhand smoking sometimes the exposure can be longer than people who smoke. Why? You're talking about kids, right? So you talk about kids, if they grow up in a household that is smoking, that has a smoker, they would have a much longer exposure to smoke than other people because their exposure to the secondhand smoke starts when they're already very, very young. So secondhand smoking does definitely have a link to a strong link to lung cancer. So I advise always to patients who are exposed to secondhand smoke is one, to advise the smoker in the family, or if it's in the office or somewhere, really you need to give them advice about education about why they should stop smoking. Now, often that may not be easy. We understand for people to try to persuade their family members to stop smoking. Then the second best thing is to make sure that the smoker understands that he's putting his family members at risk and to minimize that exposure. So he really has to smoke in places which doesn't expose his family, whether that's in the balconies, outside, but certainly not in the home as well.
Yeah, and I believe for secondhand smoker is actually much more difficult to determine how much is the exposure because when you talk about smoker, you can ask the questions whether you smoke how many cigarettes per day. Yeah. But any measurements for secondhand smoker that determine their risk.
Yeah, so we can't, it's very hard to estimate how much exposure and how much a person is at risk. We just know that you're at higher risk if you're exposed to secondhand smoke, but it's difficult to say that, you are 3 times more likely to get lung cancer compared to somebody else. Those numbers are difficult to establish.
Yeah, I understand that. So the next question is, I believe it's from an ex-smoker. So the question is, as an ex-smoker, when I still at a high risk of lung cancer, so the question is really, let's say you smoke in the past, you decided this not go, you stop smoking, you still have a risk of getting it.
Yeah. Okay, so the important thing is that you are an ex-smoker, right? So you've actually stopped. Now, that's fantastic because once you stop, your risk for lung cancer will start to drop. Now, and it's estimated that if you have stopped smoking for about 15 years, your risk, right, drops really significantly, not to zero, but by up to like 70% compared to if you had continued smoking. So the longer the time from which you have stopped, so obviously if you only stopped like 1 month ago, then it doesn't make too much of a difference yet. But the longer you stay off smoking, with each passing year, your risk drops. So hence, that's why the message to smokers is to try to stop, because it does work. That the moment you stop smoking, your risk declines with each year. So the longer and longer you can go without smoking, the better the chances of your outcome. All right. Now, of course, I have many patients who, when they see me and they're already diagnosed with lung cancer, and I ask them, "Do you smoke?" They say no. Then I ask them when they stopped. They say last week when they found out they had lung cancer. Now that's often that's a different thing already. They think then that their smoking may help with their treatment, and it does. If you are a smoker and you have been diagnosed with lung cancer, it's still important to stop smoking because if you keep smoking, often even the smoking interacts with a lot of our treatments. So the treatments may sometimes be less effective because of the smoking. But by then it's a bit too late. So really the time to stop is to stop now when you're still well. And with each passing year that you remain well, your risk of developing lung cancer drops.
I think one of the related question is, I think what will be relatable for a lot of people is that because a lot of people might, when they are youngster, they might, because peer influence or perhaps in Singapore, specific in NS environment, they might actually get to smoke for a short period of time, like just within that 1 or 2 years, but they actually stop smoking right after that until the adulthood. In this group of the individual, what is their risk of developing lung cancer?
So once again, good question. How much you have smoked is also very important. So if you smoke only for 1 year and then you stop for 15 years, your risk is extremely low. So whenever you see your doctor may often ask you, if you're a smoker, how many packs would you smoke a day and how many years did you smoke for? Now, if you smoke 1 pack a day and you smoke like for 20 years, then we consider that as something what we call 20 pack years. And the more your pack years, then you're higher your risk. But if you only smoke for like 1 year, 1 pack a day, and you have a 1 pack year smoking history, then your risk of lung cancer, of course, is low. So once again, that message to stop smoking is a critical message that we always want to get across.
Okay, so I believe I also read something. I believe it's more like a myth. Is there are some things circulated online. Even like you smoke 1 cigarette could also significantly increase your risk of getting lung cancer. So is that true? Just
no.
Smoke.
No. Otherwise, even in army also, I'm exposed to all the second-hand smoke because I like to hang around the smokers in army to keep all the mosquitoes away. But no. I think if you have very limited exposure, you don't have to worry too much. Yeah.
Okay, but besides cigarette smoking, is other type of the smoke perhaps from the when you're let's say in the household you are doing praying all this, you got all the incense. Is all this could contribute to the risk factor as well?
Yeah, look, so of course, we've only talked about smoking, but there's obviously other risk factors for lung cancer, other kind of so-called, gases that may increase your risk of lung cancer. Now, incense and all that, we probably not enough evidence to say that, yes, those kind increase your risk of lung cancer. But other kind of chemical exposures that we know well about, things like in the past when they used this chemical called asbestos to build ships and to build houses, and if you're exposed to chemicals like that, you would have an increased risk of lung cancer. And then in a lot of countries where there is what we call uranium in the ground, exposure to that also increases your risk. But things like joss sticks and all that, we don't have enough evidence to say that definitely increases your risk of lung cancer.
Okay, no. So we'll continue with some questions from the live Facebook chat.
Yeah.
So the next question is, how long can a stage 4 non-smoker lung cancer patients carry on with maintenance chemo?
Okay, so that's a good question. So some patients, and I assume this person who asked this may be on maintenance chemo. Some patients, not everybody is on maintenance chemo, it's important to know. So once again, I say you can't compare notes, but some patients, we will put them on maintenance chemo therapy after they finish their main course of chemotherapy. So often that main course of chemotherapy may be about 3 months of fairly strong chemotherapy. And then after that, when the strong main course of chemotherapy has done its job, then we put them on maintenance chemotherapy. Now, why do we do that? The reason being that when we give that strong chemotherapy, traditionally what we found is that unfortunately the cancer relapses or progresses very quickly after finishing that main round of chemotherapy. So what we found out a few years ago, is that the patients who are put on maintenance chemotherapy their cancer tends to be under control for much longer. Now, how long do you have to be on maintenance chemotherapy? There's 2 things generally that will make us stop maintenance chemotherapy. One is side effects. So if you are having a lot of side effects from maintenance chemotherapy, then your doctor will have to balance it up and say, hey, I'm giving you chemotherapy that's controlling your cancer, but you are suffering and you have no quality of life. So sometimes we may stop that early because you're having a lot of side effects. The second most common reason is that the cancer actually is no longer under control under the maintenance chemotherapy, meaning that your cancer actually has come back. So maintenance chemotherapy, usually we just keep it going, and we just keep it going and going until one of these 2 things happen, which is that the too many side effects and we stop, or the cancer has actually come back. Now you can ask, does that mean I go on forever? You know, I never ever stop until the day I die. In a way, no, that will not happen. Because why? Because unfortunately, a lot of cancers do come back. The average patient on maintenance chemotherapy within within about a year or two, the cancer would actually have come back. Now, for those who are the special ones or the outliers who do very well and the cancer actually stays under control for a long time, then that's really a discussion with your treating doctor. You know, how long? Because if, like, say, after like 2 years, 3 years, and while your cancer is still under control, then I think it's a discussion that you need to have your doctor whether he thinks it's safe for you to take you off that maintenance chemotherapy.
Okay, thanks a lot, Dr. Yeap, for help to address that questions. So I now we would like to move the topic towards more on the precision oncologists, because after all, I think this, as Dr. Yeap mentioned earlier, this is one of the big topic, especially when we talk about lung cancer. So we'll start with one of the questions from the audience. So the question read, is genetic testing a standard protocol for all lung cancer patients now?
Yeah. Okay. Very good question. Now, the first thing to define is to define genetic testing. The genetic testing that we do for lung cancer is not the same genetic testing. In case the person who asked this question who was tuning into the breast cancer talk earlier, it's not genetic testing for, like, say, what we call the BRCA mutation. That kind of genetic testing is the testing to see whether you got cancer because you inherited that a gene from your parents. We don't do that kind of testing in lung cancer because we haven't found a lung cancer, gene that's inherited or passed down from our parents. The genetic testing that we do for lung cancer is we're actually doing the genetic testing on the cancer itself. So not on you, person, but on your cancer. So we either take the cells from the biopsy or from the blood, because your blood often has what we call circulating tumor cells, and we actually check the genes of that cancer. Now, that kind of genetic testing, yes, is done for almost all lung cancer patients. The only lung cancer patients that may not get that kind of genetic testing are sometimes what we call small cell lung cancer patients, because we rarely find any significant genes in that kind of lung cancer. But almost all other lung cancer patients, yes, we will do it. Why? Because like I mentioned earlier, the treatment, the main thing why we do the genetic testing is to decide on the treatment that will work best for you, the patient. So every lung cancer is a little bit different and may be driven by different genes. And so we need to find out what is that driver mutation, or if there's any in that lung cancer. And if we do find one, then we treat it with a targeted therapy. Now, sometimes you don't find it, don't have to worry, because patients that don't have driver mutations, there's also very effective treatment for this. And I actually see the next question already, so I might as well talk about it. I think somebody has asked and said for lung cancer, immunotherapy effective. So I might as well go into that. So for patients who don't have a driver mutation, we often then use what we call the biggest breakthrough in oncology in the last few years, which is a whole new class of treatment of cancer called immunotherapy. Now, immunotherapy, how it is not chemotherapy. It's also given through an infusion like chemo. But immunotherapy is a drug that comes into your body, boosts your immune system, and your own immune system fights the cancer. Immunotherapy has become one of the biggest treatments available for lung cancer. Why? Because a lot of lung cancer patients respond well to immunotherapy. So even if they don't have a driver mutation, they may often have a type of cancer that is responsive to immunotherapy. So patients who don't have driver mutations usually will end up on immunotherapy, and the treatment is often very good as well. Okay.
So for immunotherapy, usually how you determine a patient will be eligible or will be suitable for immunotherapy? For all patients?
Generally almost all patients are eligible for immunotherapy at some point. It may not be the first time, your first line treatment, because like I said, sometimes if you have a mutation, then it's better to treat that to stop that driver mutation. But in the event where a patient doesn't have a driver mutation, then immunotherapy is often an option. Now, but sometimes it may work well alone, and that's what we use this particular biomarker called the PD-L1. And if you have a high percentage of this PD-L1 in your lung cancer, then sometimes immunotherapy alone is enough. But even if you don't have a high percentage of this biomarker called PD-L1, it can be negative or low, like 1%. Immunotherapy also still works, but it will usually have to be done in combination with something else. And that combination is often either together with chemotherapy or with two immunotherapy agents. So most patients are candidates for immunotherapy at some point. Even patients with a driver mutation, when their cancers progress, sometimes in the second line, immunotherapy is also used for them.
Okay. So I believe there's a lot of options out there. So you mentioned about targeted therapy, including the most important one like EGFR. Then we got this immunotherapy. So how do you decide which treatment option to go first? Or is it individualized, or is it something that already protocolized?
Okay. So you see that thing called CARIS-MI down there, molecular intelligence. So those are what we call genetic testing, right? And so like I said, we talk about trying to find the genes. The important thing there, we now have all these genetic panels, genetic testing that we do. And once we do all this, so we often will do, how we do the genetic testing is all this what we call genetic profiling. CARIS is one of them. There are others as well. And we use them to find out the genes, and so then we can treat the cancer according to what genes we find. Sorry, actually I missed the second part of your question. You asked kind of two questions. What was the second part, Wentong? I think I may not say fully. Yeah.
Yeah. No. The question is how. I think you so how you actually decide which treatment options to go first.
So using these genetic platforms, we will come back as with a particular, whether you have a driver mutation or not. If you have one, then we will target the mutation using the appropriate targeted therapy. And if you don't have one, then we will then look at the other biomarkers as well. And then we decide the treatment, whether it's chemotherapy or immunotherapy or chemotherapy with immunotherapy. So that's where personalized medicine, is all very different for every single lung cancer patient.
Okay. So the next question is very related with what we have discussed now. So when the patient is treated with all this personalized medicine, how effective it is?
Okay. So so imagine why it is very effective. Okay. The response rates are very high, and the reason why is because you know what is driving the lung cancer. So in the past, when you go back like 20 years ago, we didn't know all this sort of things. So we just hit everybody with the same drug. Everybody with lung cancer, even though there may be different mutations driving it, everybody gets the same drugs, And so those times the response rates are low because we're just like throwing like a big concoction at it and hoping it works. Whereas nowadays, it's almost like a sniper aiming its target. You know what the target is, and you're going straight for that target. So that's why personalized medicine is important, because the treatments actually are much more effective. The response rates tend to be a lot higher. So for patients, for example, with an EGFR mutation, we often just start them on tablets, and there's quite a few tablets, but the most, probably the most known as what is the most effective one right now is called Tagrisso. And Tagrisso, the response rates are very high, and almost every patient, and it's fast, so often you find the cancer shrinking very, very quickly. So it is effective. Number one, is the course of treatment longer? Yes, because often chemotherapy, we can't keep patients with strong chemotherapy forever. Maintenance chemo can go on for longer, but often that treatment, because of all of its side effects, chemotherapy is a short course. Targeted therapy though has a lot less side effects. They usually are just tablets for most people, and so you can be on it long term. And we're talking about it for many, many years, because the side effects are very, very minimal, similar to patients who have chronic diseases like high blood pressure, diabetes, and on tablets all the time. Many of our lung cancer patients are now like that as well. They're just on tablets that can keep the cancer under control for a long time.
Okay. So I believe, as we learned from you, targeted therapy actually seems to be like quite something rather promising because it's effective, it's very safe. But is it any clear disadvantages associated with the targeted therapy, or in fact with immunotherapy? So is there any disadvantages?
Okay, the most obvious disadvantage or negative thing about these targeted therapies and immunotherapy. So I always say it this way: there are very few toxicities or side effects of these targeted therapy and immunotherapy compared to chemotherapy. But there's one large toxicity of these, and that is the toxicity to your wallet. You know, it is expensive. So the big problem with a lot of these immunotherapy is the cost. Now, thankfully, you know, chemotherapy is generally, because we use drugs that have been around for a long time, usually a little bit cheaper. But all these targeted therapy drugs, your treatment per month can easily come up to, you know, $10,000, sometimes even. Now, the drug companies and the oncology community in general are addressing ways to make sure everybody has access to all these drugs, regardless of cost. So there are many drug companies that now make sure they have special programs to make sure that patients still get treatments, even if they can't afford it. So in a way, we're quite fortunate in Singapore. I think most people, despite the cost, are able to, either through government subsidies or through the special programs, through the companies, are able to get access to these drugs. But really, aside from the financial side effects, obviously there are some side effects as well, but they tend to be a lot better tolerated, you know, especially the targeted therapy. Some of people might get rashes, diarrhea, and tired, but that's about it. Their hair will not drop for most targeted therapy agents because it's not chemotherapy. They rarely have nausea, and they usually have a fantastic quality of, a good quality of life while they're on these tablets. Immunotherapy is also similar, you know, even though it's not a tablet, it's an infusion. But it's much better tolerated than chemotherapy as well. Your hair will not drop. You won't feel like vomiting. Your appetite remains good. But there are unique side effects to immunotherapy. But usually, the close to almost 90% of patients who take immunotherapy will have no side effects. You know.
Okay, thanks a lot, Dr. Yeap. So I think with that, that will be our last question for the section as well. So thanks a lot, Dr. Yeap, for actually have a good discussions on the lung cancer discussion as well. So with now, we'll actually welcome back Dr. Lee as well to our panel. Hi, Dr. Lee. Okay, so I believe that we already addressed most of the questions under the Facebook live chat today. So perhaps to just wait 1 or 2 minutes in case anybody have the last question to ask. Yeah. So I think just for the endings or part of the endings, I think I will throw one question to either of you, or in fact both of you. So is there any general advice that we'll give to our patients or perhaps individuals? Let's say you want to manage our risk of getting a cancer for either lung cancer or breast cancer. So is there any key things or lifestyle modifier that we could do to actually decrease our risk for getting a cancer? Because we know this cancer, after all, is a terminal disease that nobody want to call it. So is there any general advice for people? So perhaps we can go for Dr. Lee first.
Okay, so just to have a more positive message when we are closing, cancer, not all cancer are terminal. I mean, if you are diagnosed early, it's very curable. So you need to end on something positive, right? So I think it's important to have a healthy lifestyle. Like I keep saying, you know, that to my patients, and sometimes they may even think that I'm their trainer because I tell them to exercise, you know, 150 minutes a week. So if you divide it, maybe exercise 5 times, 30 minutes each. So healthy lifestyle is important. Keep your weight in the healthy range. Try not to drink and try not to smoke. And also discuss, you know, your lifestyle and all that. Talk to your doctor. So for women, I think it's important to be aware of your body. So I will advise like regular breast self-examination. If there are any abnormality, you know, highlight that to your doctor, because, you know, I've seen cases where, you know, they harbor a breast mass for 4 years and they could be scared, they could be in denial. By the time they see a doctor, it could be too late. So it's important to, you know, be aware of your body, do regular breast self-examination, talk to your doctor if they detect anything abnormal. treatments are really improving, like what Dr. Shang also mentioned. Treatments are improving. So, you know, if you are detected early, it's really highly curable.
Okay, how about you, Dr. Yeap? I believe not is number one message for you.
Comment is that you all must listen to her because she preaches. She exercises a week. So her patient should listen to her. The general advice is really exercise, you know, for breast cancer self-examination. But of course, the one advice that everybody wants, I think Dr. Lee and I get asked this by every single patient, is what food to eat and what food not to eat. You know, and unfortunately, that's what everybody wants to know. But the first thing to say is, in terms of what food to eat to prevent cancer, there isn't really any superfood lah. Okay, there are some supposedly good ones, herbal supplements and all that, but we as doctors have to say that there just isn't, the evidence for it is not that strong. And let's be very honest, if there was very strong evidence that there's this particular food that we can eat that will prevent cancer, everyone will be eating it. And but the reason why not everybody's eating the same kind of food is that there isn't any one food, whatever that people may say, that can help prevent cancer. But there are obviously some foods that we need to cut back on, you know, well proven to be linked to cancer in general. The most so the ones that you hear about commonly are things like processed meats, you know, fatty foods, an unhealthy diet full of a lot of just meat and unhealthy food, and little fruit and veggies is linked to a lot of cancers, especially like colon cancer. So generally, a healthy, balanced diet is what we always, and I know that everybody thinks that's what doctors always say, but that's really the truth. You know, you don't have to go crazy with your diet, but keep it in moderation. Cut down on your processed meats, cut down on your fatty food, probably on your processed sugars and all that, and then you're doing the very best you can for your diet in terms of preventing cancer.
Yeah, thanks.
And alcohol, you know, alcohol is strongly linked to many cancers, so you really should you know, minimize your intake of alcohol.
Okay, thanks a lot, Dr. Lee and Dr. Yeap. I believe this great advice is not only applicable for cancer, but in fact it's actually for the preventions for most of the disease, and it's very important. Okay, so there's no other questions coming in from the Facebook live chat. So I think we will end the section here. So thanks a lot again for Dr. Lee and Dr. Yeap to be our panel for today. And for the audience, in case you have any further questions after this event, or for those actually listening to the recording of these Facebook Live events, you might actually address your question, direct your question to either Mount Alvernia Hospital or the Icon Cancer Center. And I believe they will be more than happy to direct your question to the relevant expert, even offline as well. Okay, so thank you everyone, and have a good day.
Thank you.
Okay, enjoy your weekend.